This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA in the University of Utah. Today, I'm speaking with the recipient of the American Academy of Neurology's President's Award, Janis Miyasaki. Janis is the Neurology Division Director in the Department of Medicine at the University of Alberta and the co-director of the Palliative and Advanced Symptom Management Clinic. She has demonstrated leadership in the AAN over the years. She's been a member of the board of directors. She's been the treasurer. She's been the vice president of the AAN. During that time, she has served on many committees in the organization, including brain health, education, meeting management, practice. I think I'm forgetting a few. Janis is widely recognized for her pioneering work in palliative care within neurology and leadership in health systems innovation. Many of you will know her as a leading voice in advancing really compassionate, patient-centered care in movement disorders and beyond before these were buzzwords. Her career has been marked by advocacy for integrating the palliative care principles into neurological practice, again, before we were used to hearing about this. So many years ago, Janis started this work. And Janis, it's an incredible honor to receive this award, and I want to chat with you today about some of the things you've done and really to get some of your advice. We live in challenging times to practice neurology and medicine, and I'm really hoping to hear from you a little bit about your journey, your values, and maybe some lessons you've learned along the way. So thank you so much for joining us. And I want to start way back at the beginning. Can you tell us what drew you to neurology in the first place?
Thank you, Stacey. And I have to say, what brought me to neurology was really about a mentor. And I think many of us have this story. I had a wonderful mentor, Peter Ashby, who was a neuromuscular specialist, and he had a wonderful, logical way of teaching that I could follow. And he was just so gentle, and I was just hooked from that moment onwards. And my journey through neurology has really been about just being fascinated and amazed. And even today, I'll be on the wards and I'll just say, wow, look at everything we learned today.
Yeah, same. I think all neurologists share this. It is a field, and I say this to trainees, if you go into neurology, you will never, ever be bored, but also you will never stop learning. So along those lines, learning and then innovating, tell us more about how in your practice you began to integrate palliative care into neurologic care, because it really was not always so. I remember this was not really something that we talked about, but now I go to the Academy of Neurology meeting and it is just understood that this is, of course, so important. So can you tell us about that?
Certainly. It was at the American Academy of Neurology that I was first introduced to palliative care conducted by a neurologist. It was Jerry Current, who was always giving the seminar on palliative care. And as he talked just about thinking about that holistic approach, approaching the patient and family, I thought, oh, this is what my Parkinson patients need. And that they give so much to us because they participate in clinical trials. They allow us to teach our trainees, and they answer endless surveys that are research projects for our trainees. And I thought we need to give something back to them when the traditional medical approach is no longer working for them.
So tell me what era was that at the AAN when you were first attending those palliative lectures? I never got to hear any of those.
It was in the early 2000s. And I started saying, I think palliative care would be good for Parkinson's disease. And people said to me, Janis, stop talking about that. And the reason was because we were going to find a cure in our lifetime. That was the big slogan. And so me talking about palliative care was very out of step with what people were talking about, and probably in retrospect, threatening. I thought it was just trying to do good for our patients and families. But people found it very threatening. And I realized then just me talking about it and trying to incorporate a palliative care doctor into our clinic was not going to be enough. What I had to do was figure out what was important to academic neurologists, because I was at the University of Toronto at the time. And what's important to academic physicians are grants and publications. So I started writing grants. I had never been taught to write a grant. And on my first grant to the application to the Parkinson Foundation, I received one. And I was shocked. And I thought, now I have to do this. I have to implement a program. And it was a challenge. And I spoke to palliative care teams from cancer, and the nurses said, "You're so brave." And I said, "Why are you saying that?" And she said, "We've been here for 15 years and there are still oncologists who won't even talk to us. You're going to have a much harder time with neurology." And I was like, ooh.
There's a lot in what you said there. One, I think it really is in framing, right? I think it's so hard for all of us to take a criticism from our peers. I'm imagining what that must have felt like when they said, look, no, this is not an avenue you're going to go down. We don't need palliative care in Parkinson's. And it sounds like that was a pivotal moment, right? Because these were colleagues, these were peers, and you knew maybe in your heart, no, this is a need. Is that part of how you recollect?
In fact, Stacey, they were more my superiors. These were people who I really respected. These are the lights of movement disorders. And I was just struck by how many of them said, nobody wants to hear that. Please stop talking about it. The Parkinson Foundation, after they gave me a grant, then they gave me a venue to speak about it. I spoke at their Center of Excellence meeting, and the nurses came up to me and said, after patients stop coming to our centers, they keep calling us. What you're doing is so important. Don't stop. And that just affirmed what I was thinking, because those are the people who were hearing the calls of desperation, the calls of, I don't know what to do, the calls of the nursing home doesn't know what to do with my dad's meds. And so they gave me the strength to go on and know that there was a need out there. It was just invisible to the investigators.
In a 30, 60-minute visit, you just don't get to that level, especially if you're directing the conversation and not directing it toward that. If you're not saying to the caregiver, what's the biggest challenge on a daily basis? So let's talk more about your approach to patient care. What would you say, if you had to articulate it, are the core principles or the habits that guide your daily patient interactions?
Once you become a neuropalliative provider or specialist, you never stop having that mindset of thinking about the entirety of this patient's life. And what are the patient's goals? Some of my patients' goals are, I want to play golf. Some are, I want to keep working. And others are, I want to connect with my family and to help them plan to make those goals. And so before I go into every meeting, I think of what has been the challenge for this patient, or what are they calling about a lot? And that is sometimes speaking to what's really bothering them at their core, or sometimes not. But that this is a person who is suffering. I am here to relieve suffering, and I will do my best.
Yeah, there's a lot of power in saying that, right? I think somewhere in the course of our medical training, we all say that, or we think about that, right? When we're writing those personal statements and examining our motivations, right? Relieve suffering. But it's challenging, right? When you get down to it on a daily basis. And so clearly you're keeping that front and center. I imagine what you're not saying is all the obstacles and the elephants in the room that come between that. So you center yourself on that before you go into every interaction. Is that right? So relieve suffering, open the door.
You're right, Stacey. We take a group of people who have incredible compassion and a desire to do good. And then we put them into this kind of machine to cram a lot of information in their heads. And then they're put into systems where they are assessed on how many times they wash their hands, how much time they spend in an encounter, when do they close their encounters, how many patients can they see, and what is their Press-Ganey score. And you think like we as a system have decided there are certain things that are going to be measured, often because it's easy to be measured. But is that the most meaningful thing? And as soon as you create a measure and you dangle it in front of really intelligent, high-achieving people, they're going to make sure they fulfill that measure. They're going to be super awesome, 110% on that measure. But do they lose a little bit of that wide-eyed, compassionate medical student who first stepped into the medical school on day one and said, I'm here. I'm going to change the world.
Yeah, no, it's the reality, isn't it? And worth discussing so that we can examine it and bring it back around for ourselves. So you've done a lot. When I was preparing for our discussion today, I saw, in addition to all the academic stuff, you spent some time in private practice. You've already alluded to the fact you've been in a couple different academic institutions. If you were just starting out again today, obviously you've made some great contributions, but knowing what you know now, would you change anything about the path? Would you even dare say shift a focus at all within neurology? Maybe I'm asking with the benefit of hindsight, what do you see next? Are there areas where you'd go back 10 years and say, okay, this is going to become an area that desperately needs our attention in the future. So should I focus on that now? What do you think? If you would, it's a two-part question. Would you change anything, and give us a little bit of a look forward from your perspective too?
Stacey, that's an interesting question because it's really a philosophical question, right? Would I still be me if I made different choices 10 years ago? If I had decided the future is genomics, I'm going to get myself a little genomics machine and genotype all my patients, would I still be me? I think I wouldn't be. And so I know that there's such a drive for graduates now to know what they're going to do, get a PhD, get your K award, get your R1 award. And I think that yes, focus is good. But I also think I meandered around, and that gave me so much richness in my experience that it was helpful. So I started in clinical trials. That taught me about what are appropriate measures, how to create measures if there aren't existing measures, how to get people to really engage in doing good as a group. And it was through equity, really. And that was with Ira Schulson and Stan Fahn and Carl Kieberts. They were about equity, treating all investigators equally. And then I started doing evidence-based medicine, and then I learned all the mistakes that were happening in clinical trials, not mistakes, but maybe ways to make it better. And then how to get people to actually read guidelines. It's fine to spend the hundreds of hours it takes to create a single guideline. But if nobody reads it, that was a waste of time. So how do you speak to people to get them to do the right thing? Because people will do the right thing if you make it easy. Don't make it hard. Don't make it sound like I'm the expert who knows and you have to memorize all this stuff and pages of information. I always approach it, it's not rocket science. If I can do it, you all can do it. So I think that all those seemingly off-track things I did helped me to become who I am and helped me be better at what I do.
Yeah, and what I'm hearing, it's incredibly important to you, no matter what you're doing, that it has to be meaningful. And so you're not going to do something because it leads to success or a grant, you're going to do it because it's meaningful. And then the other thing I'm hearing here is the fire in the belly, right? Like you are like a dog with a bone when you are going after something. Is that fair? Has anyone accused you of that before?
Absolutely not. Never, Stacey. Yes. Some people say, oh, goodness gracious, just give that woman what she wants so she'll go away. And an example is I still do hospital duty. And one week, 5 of my nurses were assaulted 7 times. And so I sit on a lot of advisory boards as a senior leader, and I'm hearing all these things about we have to be nicer to patients and families, which is true, but there's no reciprocity, right? It doesn't recognize it's a relationship, and there has to be mutuality in that relationship. It doesn't go one way. It has to come back too. So I was just becoming more incensed, and I put up my hand and I say, I really believe everything you're saying. I also believe patients and families have responsibilities when they're in the hospital. And that is not to verbally abuse my staff, not to swear at them, and not to physically assault them. And there was silence. And then all these hands came up of the other leaders. I agree with Janis. But until someone says it, how do these people who many of them are doing less and less clinical practice, how do they actually know? And so I view myself as that information conduit to the senior leaders so that they can hear the distress of my people and that we can do better for the entire system, because it has to be that it can't just be the entire focus is on patient and family. The focus has to be on the system that is working to help that patient and family. Because if the people who are working in that system are not well, then it doesn't matter what metrics we put out. We will not succeed.
You hit on the fact that in order to be an authentic leader, you've got to be doing it, right? You've got to be having the sleepless nights. You've got to be on the inpatient service. You have to be living it. Otherwise, you're preaching from on high. And if there's one thing that clinicians can smell from a mile away, right? It's someone who is not in it with them, right?
Absolutely. I think that something I've started doing in my spare time is volunteering at the hospital. And I take my dog, Petunia, who is very sweet. And they said, what patients do you want to see? And I said, oh, no, she's not for the patients. She's for the staff. And they were silent. And then they said, oh, yeah, what a great idea. So for the past month, I've been taking her for 2 hours a week to visit the neuroscience staff. And the response has been really positive from the staff and the patients, but mostly the staff. They say, this is our dog. She's for us. Thank you for thinking of us.
Yeah, it doesn't take much these days because there's a culture that we live in, right? Like you're there to serve, which is, again, what we were talking about earlier. You're here to serve. You're here to relieve suffering. But turning that around and getting the nuance of, in order for you to relieve suffering, you need to be seen and taking care of yourself. So both sides of the coin is what I'm hearing you say.
And I don't want to sound perfect because I think sometimes when people are interviewed and here is Florence Nightingale running around with her lamp, because I do have interactions where I just think, whoa, that just went sideways all of a sudden. I'm reflecting where it went bad and I can't really pinpoint it. It was just all bad. Or even the palliative care doctor said, I guess they won't be coming back. But the point is, we tried. And if things are not going well because there are systematic problems, like you aren't sleeping, you don't have time to eat or go to the bathroom, like what can you do to actually recognize your own needs? Because I think doctors and nurses and many of our staff often put their own needs so far back and they have suppressed it so far back. But you cannot keep suppressing it forever because it comes up in anger or resentment or just complete exhaustion. So it's important for us to recognize our own needs and to say it's reasonable to have a 15-minute break just to have something to eat or just to put on your noise canceling headset and remove yourself from the chaos of the hospital and to look after these things, but also to look after each other. Because I frequently say to the residents, have you eaten? And they know I'm going to ask them. So mostly the answer is yes. Before it was often, no, I haven't. And I said, now we're going to go and have something to eat and drink.
Yeah, I think when I was a resident, I would have said no if the attending was going to treat me. When I think back about it, the worst care that I've given across my career was when I was the most sleep deprived. The care that I'm ashamed of because it wasn't my best work. So it was just sleep deprivation. You can't really see through that in the moment, but we digress a little bit, right? Because I just love hearing from you and your approach and your thought process. But I should probably talk a little bit about what you've done for the AAN. And I think maybe you'll let us peek behind the curtain a little bit here. You don't get the AAN President's Award because you served on a committee for 1 year. Tell us what this really looks like. Now, I like to think like all AAN volunteers, it brought you joy and that's why you kept coming back. But it doesn't bring you joy at all moments. This is work. Tell us what has been the hardest over the years at the AAN and what sort of time commitment. Give us a real peek behind the curtain here of what was involved in really giving yourself to that organization.
Stacey, that is a loaded question. I would say it has been incredibly rewarding, and what was the most rewarding is being around people who also believe medicine is a calling. And that is a strong ethos throughout the volunteers at the AAN because they are all busy and yet they find time to do this work. So the first committee I was put on was the Technology and Therapeutics Assessment Committee, which was a fancy way of saying it was guidelines for technology. And so I learned a lot from that committee, but it took about, I would say if you were doing it well, it was at least a 0.2 FTE job.
I believe it. I do think those are amongst the hardest service committees in the AAN.
It is the most intense because at the beginning we relied solely on volunteers. And then there were a group of us who had learned how to write guidelines enough that we were guiding them as the committee members. But it's very hard because you're taking authors who have very strongly held beliefs and often don't see their own bias. And you're asking them to dispassionately look at the evidence and rate it appropriately. And the answers I had were quite amazing. Of course, it's unethical to do a placebo-controlled study because we know this works. But how do you know it works? And also the challenge of the committee that was used to moving fairly slow. So when I became the chair of the committee, right before it, the committee was putting out maybe a guideline every couple of years. And I said, okay, here is the scoop. Your colleagues are investing in this committee because they don't know what to do with technology. If we produce one guideline every 2 years, we are failing them because technology is moving out faster than that. So how can we meet their needs? And so we started to become more focused. And by the time I left, we produced over 12 guidelines in 1 year. And so that was an incredible amount of work, but it was also really at the beginning of each meeting saying, we are here to serve the membership. We are here because your colleagues cannot read 100 papers to figure out what they should do.
So you're going to do it, right?
So we're doing it. We as a group are doing it. And they rely on us now. Because by that time, members were starting to say evidence-based medicine was important. They wanted to do these things. So that required a lot of effort. And at the beginning, when I was a committee member, I said, a lot of members say that we are taking away their autonomy. And so I went around the country speaking about evidence-based medicine to sometimes very hostile audiences. And so I learned how to deal with that and not take it personally. Evidence-based medicine was not my baby, but I was trying to explain why we were expending so much effort on this And it was to really make things better for our patients and also easier for our colleagues.
Yeah, so important, right? If we're not practicing evidence-based medicine, are we really fulfilling our mission to move things forward and provide the best care? But so much easier said than done. So that was that committee. Give us a whirlwind tour of a few of the others.
Oh my goodness. Practice improvement. We had to summarize these vast guidelines down to a single page. And once again, that was something I proposed. I said, nobody's going to read the whole paper. We have to just make it one page, and one page for the patients, because patients ought to know what should be happening. And so they became very popular, but it takes a lot to actually condense the essence and convey the information in one page when someone has spent many pages explaining all the evidence. And I've been on the education committee, which we read every single comment that comes back from the annual meeting, and trying to go through that and make the meeting more accessible, make it better value for our members. But that was also a lot of background time to prepare and do the right thing. And then every committee then has working groups, because it's not just, this is your job, you plod through it, but it's, hey, this is an emerging issue. What should we do about it? So you create a working group. The working group looks at it, examines all the evidence. And I have to say the AAN staff are absolutely tremendous. Their ability to do an environmental scan is really unsurpassed. It's really great. They're so high functioning. They are the highest functioning association staff I have ever worked with. And then we have the working group, and then we decide on a way forward. So everything that I did at the academy can also be generalized to your local institution. And you can learn so much if you're paying attention to how people interact, how people manage a meeting, how you get everyone to contribute, but also how you keep focus on what needs to be accomplished and what is sustainable and pragmatic.
I think, again, a lot packed in there, more than just a couple little nuggets of advice, but it's so helpful. I've loved speaking with you. There's so much that you speak to, and you're an incredible citizen locally and regionally. I've only ever seen the AAN piece from afar, but it really helps to fill out the whole picture of a passionate neurologist who, I dare say, you follow your passions, even if it, as you said, is a wandering path. And maybe that makes for the best end product. I just want to thank you for sharing some of your experiences. And again, I've been speaking with Janis Miyasaki. She was this year's recipient of the AAN President's Award for the work done for the Academy, but obviously so much richness there beyond that as well. So thank you for your leadership, for all the volunteering that you did. You can learn more about this if you want to go on the webpage and look up the AAN's President Award, because I didn't get into all of her accomplishments. Congratulations again, Janis.
Thank you, Stacey.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.